good morning or good afternoon, depending on the time that you are considering. So, why to talk of comorbidities in a Liverpool course? Because more comorbidities means more drug prescribers, and this means more drugs is prescribed. And of course, if you have more drugs, this may result in more drug-drug interaction. So these concepts are well shown in this Spanish studies. As you can see here, for every decades of age, if you compare HIV positive versus HIV negative patients, HIV positive patients are always taking, are associated with more polypharmacy than HIV negative patients. And on the other side, as you can see, of course, polypharmacy is associated with 3% of red flag drug-drug interaction, but something like 20 to 30% of orange and yellow flag drug-drug interaction. So if you look in the literature, there are a lot of studies that have deals with the role, with the issue of polypharmacy in HIV-infected patients. As you can see here, the risk of polypharmacy ranges from 15% in Uganda to more than 90% in US. So polypharmacy is a frequent issue in HIV-infected patients. And as you can see in this figure from the review published by David Beck and Kadia Marzolini, now we have new antiretroviral regimens, but none of them is totally free from the risk of drug-drug interaction. Another easy concept is that polypharmacy is exponentially related to adverse drug reaction, regardless or not totally related to drug-drug interaction. This was a study published last year. They looked at the risk factors for potentially preventable hospital readmission in people living with HIV. And as you can see from the table, the most significant factors associated with hospital readmission was to have more than 10 drugs at discharge. So more drugs, more heavy polypharmacy, and higher is the risk of hospital readmission for adverse drug reaction. This is another study that again show the strict relationship between the risk of contraindicated drug-drug interaction in this case, and the risk of hospital admission. And you can see here, if you compare no contraindicated drug-drug interaction with contraindicated drug-drug interaction, the frequency hospital admission may increase or reduce by 20 to 30%. And of course, if in your antiretroviral regimen you have a booster-based protease inhibitor, the risk or the prevalence of hospitalizations for adverse drug reaction is greater compared with other antiretroviral drug class. And this is an experience done in our hospital last year. So again, concerning the presence of booster-based regimen, in this table, you look at 4 cases of patients from the Luigi Sacco Hospital experiencing Cushing syndrome that was related to concomitant administration by corticosteroids and a booster-based regimen. So this is a well-known red flag drug-drug interaction known for more than 20 years, but in real life, this drug-drug interaction may take place also nowadays. Again, 4 cases observed only last years, and remarkably, the 4 cases deals with corticosteroids given not by systemic administration. But for sure, there is, talking about comorbidities and polypharmacy, there is much more that we can do rather than just check for drug-drug interaction. It is important in HIV-infected patients to consider if there are potentially inappropriate medication, and if your patient is an elderly patient, you should also, for instance, deal with the issue of the anticholinergic burden. And another important condition that you should always consider and keep in mind, is the role of the prescribing cascade. So this phenomenon was described more than 20 years ago, and it is related to the fact if you start treatment, you misinterpret the adverse drug reaction as a new medical condition. So you add another drugs, you increase the polypharmacy, and you can magnify the risk of adverse drug effects. So all this, this is a background just to introduce the topic of my talk, that is the de-prescribing. So de-prescribing should be led by a qualified health professional and implies the discontinuation of a medication, or it's not only discontinuation, but also by the eventual potential selection of appropriate choice of drug to be used to treat multiple disease conditions and to avoid harmful drug-drug interaction. De-prescribing in HIV may relate to potential de-prescribing of antiretroviral therapies. And as you can see from this study, the authors looked at the role of simplification of antiretroviral therapies on the risk of drug-drug interaction. And as you can see clearly from the table, from this multivariable linear regression model, concomitant medications, discontinuing a protease inhibitor, and the switch to dolutegravir were all independent significant factors associated with different pattern of drug-drug interaction profile. De-prescribing in HIV may deal also with non-antiretroviral therapies, because antiretroviral therapies are only a part of the overall pill burden of HIV-infected patients. And this study was one of the first experienced published so far, in which the authors have done a pharmacist-led program to evaluate and eventually reduce the polypharmacy and potentially inappropriate prescribing in HIV-infected patients. So they consider some important tools such as the BS criteria and the STOP criteria. So there is no time to go in deeper, but just to say these are tools that can be used to check the appropriateness of medicine prescriptions. And what they found is that the concept that we have already mentioned before, more drugs that you are prescribing in your patients, and the higher is the risk to find some inappropriate medication. And as you can see here, according to the tools that you use, the potentially inappropriate medications were found in 50 to 60% of HIV-infected patients. What the authors have done is to apply this rule to review all the overall pharmacological therapies, and at the end that they were able to remove 25 contraindication, means red flag drug-drug interaction, and to significantly reduce the chronic medication, so from 14 to 12. So this is the first study showing the impact of a de-prescribing program in HIV-infected patients. But the third thing that you should always consider when you are dealing with the de-prescribing HIV is not only antiretroviral therapies, not only non-antiretroviral therapies, but also you should consider non-drugs therapies, such as dietary supplement, complementary and alternative medicine, recreational drug, etc. So because these approaches are used by a large cohort of HIV-infected patients, and most importantly, less than 10% of the patients inform their healthcare providers about the use of supplements, complementary alternative medicine, OTC, recreational drugs. And just to give you an example, this table summarizes our experience, the experience of our outpatients clinic dealing with the issue of polypharmacy in HIV-infected patients. The first cases deal with virological failure. Patients experience virological failure a few weeks after starting OTC supplements for weight loss. And the last 4 cases deals with the issue of acute hepatic failure in patients starting in OTC and a CAM or a supplement. So please consider also this component of the overall pill burden of HIV-infected patients. So after this background, this session should deal with clinical cases. So I present now a couple of cases. Number one is a 34-year-old man that was referred to our clinic because he reported progressive abdominal distension, prominent cheeks, dorsocervical fat pads, edema, skin fragility, hair loss, decreased libido, fatigue, depression, and hypertension. He was on maintenance antiretroviral therapy for the last 2 years with elvitegravir, cobicistat, TAF, and FTC. So we started by prescribing some laboratory tests, and the two abnormal things that we found was the very, very low and undetectable serum corticals and plasma ACTH concentration. So based on these laboratory findings and the physical assessment, we diagnosed the patient with iatrogenic Cushing syndrome. So now the most interesting thing for us was try to understand why the patient developed Cushing syndrome. So we started with the detailed anamnestic investigations, and the patient revealed that a massive use of GHB, gamma-hydroxybutyrate, starting initially as chemsex during the weekend, but now daily at high doses for potential treatment of depression. You know, GHB is a central nervous system depressant. It is in the past it was used as a solvent. And the super glue remover is very cheap. You can easily find it on in the websites. But if you look at the adverse events of DHB, it's respiratory depression, seizure, CNS depression, coma, and eventually death. So none of these adverse effects were apparently present in our patients. So we continue with our detailed anamnestic investigations, and we discovered that in the last 6 months, the patients reported massive topical application of betamethasone several times a day, so at very high doses, and also the use of repeated injection of stanozol and testosterone because of the progressive worsening of physical strength and for the loss of libido. And if you consider especially betamethasone, but also stanozol and testosterone, you can identify most of the symptoms that the patient experienced. So how was our de-prescribing in these patients? Of course, we asked him to stop immediately GHB. We stopped betamethasone, stopped stanozol and testosterone, add cortisone. Remember that de-prescribing is not only removal of drug, but eventually add appropriate medication. So we add cortisone acetate to support the hypothalamic axis and to prevent adrenal insufficiency. We add apremilast to treat plaque psoriasis. And we also decided to de-prescribe the antiretroviral therapy. So we decided to remove the booster, and we switched the patients to dolutegravir plus TAF plus emtricitabine. And luckily, the iatrogenic Cushing syndrome was totally reversible, and after 1 month, we observed a normalization of serum cortisol and plasma ACTH concentration. And we described this case in AIDS last year. The title of this case was the Prescribing Cascade 3.0 because we included also the issue of recreational drugs. And as you can see here, this is our hypothesis. So the concomitant presence of GHB, a booster, corticosteroids, anabolic hormones resulted in a vicious cycle that explained the observed severe iatrogenic Cushing syndrome. The second case is a 50-year-old woman living with HIV that was referred to our clinics because there are alterations in the ENR values. She was on warfarin treatment since 2007 for the management of deep venous thrombosis, and her antiretroviral maintenance antiretroviral regimen was based on nevirapine, lamivudine, and abacavir. As you can see from the figure, the INR was well controlled in the past 6 months, and the patient used an asymmetrical regimen of warfarin, 9 milligram daily from Monday to Saturday, and 7.5 milligram daily on Sunday. So, but she was well controlled. On November 2020, the infectious disease physician decided to simplify the antiretroviral therapy from a triple to a dual therapy consisting of dolutegravir plus lamivudine. The patient performed an INR assessment 7-8 days after the switch, and with quite normal INR values, so all is good. But in the first week of December 2020, the patient had gut bleeding while brushing her teeth. So, however, he decided not to go to the hospital for the measurement of INR because in December 2020 in Italy, we were experiencing the peak of the second COVID pandemic wave. So, for the fear of COVID, the patient decided not to go to the hospital. However, a few weeks later, she decided to go to measure the INR because in the end of December, there was a persistence of gingival bleeding. And what surprisingly we found was that the INR that was stable for the last 6 months at least greatly increased from 2.2 to 4.3, 4.4. So as first step, the attending the infectious disease physician decided to switch back the antiretroviral therapy. So the patient was switched back from dolutegravir to nevirapine. And after a few weeks, we observed the normalization of the INR. So again, 2.9, 2.7. So this case was well managed by the infectious disease physician, but the most important and interesting question for us was, why did the patient experience such a sudden increase in the INR a few days after switching the antiretroviral therapy? So, of course, the first thing is there interactions, a drug-drug interaction between dolutegravir and warfarin? The answer is no. If you look at the Liverpool website, there is a green flag, and this is expected because there are no common metabolic pathway or something like that. So the observed increase in the INR was not for sure related to a drug-drug interaction between dolutegravir and warfarin. So thinking and alternative hypothesis, this is our working hypothesis. So we assume that a DDI, a drug-drug interaction, may have taken place between warfarin and nevirapine several years ago when the patient started this combination of drugs. This drug-drug interaction was well managed by adjusting the dose of warfarin. But what is likely to have happened in November is that the switch from nevirapine, from dolutegravir, was not captured by INR because of the long half-life of nevirapine, because the INR was measured 7 days after switching the antiretroviral therapies. But when nevirapine is still present in the body, because we need at least 2 weeks to totally remove nevirapine from the body. And the COVID pandemic has created the perfect scenarios because the patient, for the fear of COVID, did not go immediately to the hospital to check for this INR. So this is in our example, in our mind, of a sort of cascade, and an example on how also a lack of a drug-drug interaction may have potential clinical consequences if not properly managed. And this case report was recently published, accepted by AIDS. So if you want more information, you can of course look at that publication. So just to conclude, our cases could be instrumental to persuade infectious disease physicians on the importance to check for novel prescribing cascade that may involve not only prescription medicine, OTC products, and dietary supplements, but also recreational drugs. So a careful assessment of the overall therapies should be always pursued before embarking in antiretroviral treatment switching, even with potentially drug-free regimen. In fact, also the removal of predictable drug-drug interaction might become clinically relevant if not properly managed. And finally, we are really convinced that the multidisciplinary-based approaches should be always pursued for the proper assessment of pill burden, drug-drug interaction, appropriateness of medicine prescription, and also when de-prescribing programs are done. So thank you very much for your attention.